one by one Nundi. We will speak on role of neoadjuvant commemoration in locally advanced rectal cancer. And second speaker will be Dr. Momita Das, who is a second year junior resident at Bakrashwani Medical College. We will speak on, we have a convention of draining and putting pack in the perineal abscess cavity. The practice is changing. So there is a publication on that. So she will present that. For the first presentation by Dr. Diptaman Nundi, who will present on role of neoadjuvant commemoration in rectal cancer.
Good morning. I'm Dr. Diptaman. The topic is short course therapy followed by chemotherapy before surgery for treating very advanced rectal cancer. In a systematic review and meta-analysis is done by Chung Caldion, Daphne Q, and others. Introduction. Recently, an increasing number of studies have compared SCR and consolidation chemotherapy with conventional CRT for the treatment of LAS. The aim of this systematic review and meta-analysis was to summarize and adjuvant HCRT followed by consolidation chemotherapy for LAS. Methodologies. This includes search strategy, records excluded 218 full text articles assessed for eligibility is equal to 74, including articles 57, single arm studies, reviews articles, conference papers, study protocol not fit for PICO criteria, and duplicate data. Ultimately, studies included in qualitative synthesis, 7 meta-analysis, 70. Inclusion criteria, HP proven rectal CA, randomized controlled trials or RCTs or observational studies, cases meeting present intervention and comparison arm criteria for treatment. Neoadjuvant SCRT composed by a total dose of 25 times, followed by delayed surgery after at least 4 weeks with or without consolidation chemotherapy during the waiting period. Neoadjuvant conventional CRT composed of a total dose of 50 to 50.4 GY, followed by delayed surgery after at least 4 weeks with or without consolidation chemotherapy during the waiting period. Exclusion criteria, synchronous metastasis, radiotherapy not meeting the inclusion criteria, delay between radiotherapy and surgery less than 4 weeks, lack of qualified analysis, single arm studies, review articles, case reports, editorials, comments on conference abstracts. Analysis. Outcome was measured in both arms on the basis of PCR rate, sphincter denervation rate, RO resection, CRM feed rate, OS, DFS, local recurrence, distant metastasis, postoperative complications. Result and discussion. SCRT and CCT provided a higher PCR rate compared to that with the conventional CRT. Relative risk 1.60, 95% confidence interval. 1.35 to 1.91 and p-value less than 0.01. Regarding tumor downstaging, 9 studies reported the comparison results and there was no difference between SCRT plus CCT and conventional CRT. Here relative risk was 1.04, 95% confidence interval and 0.75 to 1.45. P-value was 0.81. There was no statistical difference between SCRT with delayed surgery, relative risk 0.86, 95% confidence interval and 0.6 to 1.08 and p-value 0.19 and conventional CRT but a superior was observed with SCRT plus CCT where relative risk was 1.05, 95% with 95% confidence interval and 1 to 1.11 and p-value 0.04. SCRT plus CCT led to significantly better DFS compared to conventional CRT relative risk 1.10, 95% confidence interval and 1.02 to 1.17 and p-value 0.002. In contrast, SCRT with delayed surgery had a worse DFS compared to that with conventional CRT, where relative risk was 0.68 with 95% confidence interval and 0.52, 0.93 and p-value 0.02. No statistical difference in LR between SCRT and CCT and conventional CRT with relative risk 1.1 confidence interval 0.91 to 1.37 p-value at 0.26. And SCRT with delayed surgery and conventional CRT with relative risk 0.85 and 95% confidence interval with 0.24 to 3.02 and p-value 0.8. Regarding the incidences of PM, there was no statistical difference between SCRT plus CCT and conventional CRT. Relative risk here was 0.86, 95% confidence interval, 0.68 to 1.07 and p-value equal to 0.18. For RO resection rates, no significant difference between SCRT and conventional CRT was observed either with CCT or with delayed surgery. Negative CRM rates were also similar between the two groups. SCRT plus CCT had a superior sphincter preservation rate than conventional CRT. In contrast, SCRT with delayed surgery had a lower sphincter preservation rate compared to the CRT arm.
Wait, go back. Contrast SCRT plus CCT
Had a superior sphincter preservation rate than conventional CRT. In contrast, SCRT with delayed surgery had a lower sphincter preservation rate compared to CRT arm. There was no difference in postoperative complications between SCRT with delayed surgery on SCRT plus CCT and conventional CRT. Overall compliance with radiotherapy was better for SCRT with a 100% completion rate reported in 5 studies, in contrast to 1.8% to 7.7% of patients requiring dose reduction in CRT arm. No difference in chemotherapy dose reduction was observed between SCRT plus CCT and CRT arms. Grade 3 plus acute toxicity was reported by 9 studies and no difference was observed between SCRT plus CCT and CRT arms, where relative risk was 1.60, 95% confidence interval 0.91 to 1.85 and p-value 0.15. In contrast to superior outcome in the SCRT with delayed surgery arm, risk here was 0.19, 95% confidence interval and 0.08 to 0.48 and p-value less than 0.001. This is the actual the study which was conducted. This neoadjuvant short course radiotherapy followed by consolidation chemotherapy before surgery for treating locally advanced rectal cancer, which was a systemic review and meta-analysis. This was conducted in Taiwan by this group of doctors and published.
What are the conclusion of the study? They given the result and discussion.
Sir, conclusion is that SCRT followed by CCT can improve tumor downstaging and induce more PCR, which may help in sphincter preservation surgery, same as that of BFS at OS. Postoperative complications and treatment compliance of the individuals were similar to those who underwent conventional CRT.
Here, after short course, previous recommendation was short course radiotherapy 1 week gap and surgery. Now this meta-analysis is revealing that
If you have to
short course radiotherapy, again a
consolidation.
waiting period with conflict chemotherapy and then delayed surgery.
Hmm.
In conventional radiotherapy, this. But some of these, go back, some of these observations where they are saying that p-value is not significant. P-value is 0.4, yes, suppose p-value is 0.1. So in that case, what is the recommendation regarding incidence of PM? There was no study difference between SCRT and season conventional CRT, but the p-value size is not significant. Local recurrence, again, p-value is not significant. So that's what they are trying to say at the end. That this is where p-value is not significant. In that case, what is the inference?
Sir, here there is a little, I think, dilemma or some.
No, it's a meta-analysis. That should not be dilemma. They have gone through the and as standard.
See, sir, here there is saying the comment that
Because you see, conventional radiotherapy dose is higher. Dose is 50 grams. In short radiotherapy, they are giving 25 grams. Obviously, the dose is less. But if you see the complications, treatment compliance are similar.
more or less similar.
But in discussion, they are saying that compliance for short radiotherapy is more than yes, 100%. And there is 1.5 to 7% patient requiring dose reduction.
Sir, actually, the standard protocol is chemotherapy, then waiting period, then surgery, and
Not only radiation.
radiation.
Standard chemoradiation, which is for 6, because you see, there are a lot of studies where there was short course radiotherapy followed by short gap, 1 week chemoradiation, 1 week gap surgery. The conventional was 6 weeks radiotherapy, 6 week gap and surgery. What they are trying to say is you can reduce the dose of radiation.
Yes.
Short course radiotherapy and not surgery at the end of 1 week.
No, then again they are giving
Consultation chemotherapy, yes.
another cycles of chemotherapy they are giving,
Yes.
then they are going to surgery.
Yes. So in that case, they are trying to say that
They are reducing the radiation.
the results are little better. The results are little in terms of complete response, pathological complete response, sphincter preservation. But some are comparable. Some are comparable.
Some observation,
Yes,
they have,
there is some difference, but they are not statistically significant. It's actually when you present journal Karna, you should try to find out one or more such meta-analysis so that you observe that whether these two meta-analyses are conclusive. Meta-analysis is a level 1 evidence. If you have a well-conducted meta-analysis or this review, they are level 1 evidence, which can have practice-changing impact. Okay. Okay, we pass on to the next presentation by Dr. Moumita Das. Conventionally, it's a very common clinical scenario where you drain perineal abscess and then you have complications of perineal fistula. We pack the abscess cavity, but recently there has been a change in practice in some centers where they are recommending that packing does not help, rather it causes more pain and more discomfort. Dr. Moumita, you can hear us?
okay.
Dr. Moumita, you can start. Dr. Momita, you unmute and I can start.
Hello, sir. Am I
Yes,
audible, sir?
Yes, you're audible. Yes. Screen time.
Oh, Dr. Momita, are you sharing the screen or should I share the screen?
I am sharing. Good morning, sir.
Yes.
This is Dr.
Yes, screen
Momita.
is visible.
Firstly,
You
I
can
had
start.
addressing. Okay, sir. Thank you, sir, for giving me this opportunity to present in front of you. And this is my first presentation. I am going to present the journal club. The topic of my journal, postoperative packing of perianal abscess cavities, randomized control trial. This is it is taken from British Journal of Surgery, impact factor almost 9.6. This is the abstract of my journal. Background of the study, perianal abscess is very common and traditionally the post-operative perianal abscess cavity are usually managed with internal wound packing and practice, though it is a practice which is not supported by evidence. The method of the study, the post-operative packing of perianal abscess cavities trial was a multi-center RCT of adult participant admitted to an NHS hospital for incision and drainage of a primary perianal abscess cavity. And usually, sir, it is the objective was to determine whether the non-packing of perianal abscess cavities is less painful than packing without an increase in perianal fistula or abscess recurrence, which is more common after IND of perianal abscess. The primary outcome was pain result between February 2018 to March 2020, and the total number of sample size 433 who are randomized across 50 cities. And conclusion of the study, avoiding abscess cavity packing is less painful without a negative morbidity risk. Introduction. The perianal abscess is a common acute general surgical condition. 90% are cryptoglandular in origin, and it is caused by the blockage of the cryptoglandular blockage and anal of the anal gland within the intersphincteric space of the anal canal. Inflammatory bowel disease is a most important risk factor. The other important risk factor are diabetes mellitus, and perianal abscess is twice more common in men than women. Mean age of presentation usually between the 40 years of age. Introduction the management of acute perianal sepsis has remained largely unchanged over 50 years. Surgical abscess IND under general anesthesia is usually followed by continued internal wound dressing, that is the packing of the resultant wound cavity in the community until the wound has healed. Packing is an accepted treatment, but the surgical dogma is that packing reduces the rate of perianal fistula formation and abscess recurrence, but there is no evidence to support this. The objective of the postoperative packing of perianal abscess cavities trial was to determine whether non-packing of perianal abscess cavity is less packing than packing without an increase in perianal fistula and abscess recurrence. The method of this study, multi-center randomized control trial, standard two-group parallel design performed across 50 NHS Trust Hospital in England, Wales, Scotland between February 2018 and February 2020. Inclusion criteria, patient age 18 years or more than that within presenting with their first perianal abscess of cryptoglandular origin requiring an INT operation. Exclusion criteria, perianal fistula, Fournier's ganglion, Hodgkin abscess, they exclude that kind of patient. Participants were randomized postoperatively prior to hospital discharge to reduce bias through modification of the operative procedure. Participants were randomly allocated on 1:1 basis to receive the current standard wound care with internal packing by nurses in the community or to receive non-packing. Participants were recruited and randomized by surgeon and Research Center. The clinical assessor of wound healing, perianal fistula, and abscess recurrent remained blind to study allocation. The wound dressing was removed by a different member of the research team to ensure the blinding of the assessor. Procedures: all participants had standard intraoperative wound packing removed within the first post-operative 24 hours. In the packing group, the frequency, type of packing, dressing, and duration of the packing was left to discretion of the treating nurses, as is a current standard practice. If in the non-packing group, the use of external absorbent dressing or pad was again left to the discretion of the nurses and participate in keeping with a pragmatic design. The daily acute pain assessment, 0 to 100 point in visual analog score of worst daily pain, where 0 is no pain and 100 is the worst pain imaginable, and pain before the dressing, during the dressing, and after the dressing was recorded up to 21 days. Health-related quality of life score, return to work, return to daily work, participant satisfaction with wound management, and participant global assessment were recorded. Participants were reviewed in clinics at 4 weeks, 8 weeks, and 26 weeks to assess for fistula, abscess recurrence, and wound healing. Outcome. The primary outcome of this study was mean maximum pain score over the first 10 days after IND and mean of the worst daily wound-related pain score. Secondary outcome included pain before, during, and after dressing changes, post-operative perianal fistula and abscess recurrence, bleeding, requiring transfusion or return to theater, and rate of wound healing at 4, 8, and 26 weeks. Sample size calculation was based on primary outcome, mean maximum pain intensity score over the first 10 days after surgery. Sample size 432, patient was required to provide 85% power to detect a difference in mean maximum pain score of 20%. Statistical analysis. The statistical analysis was performed by the Northwest Surgical Trial Center. Analyses were performed on an intention to treat principle because it is a randomized controlled trial, retaining all participants in their randomized group, irrespective of any protocol violation. The primary outcome was defined as the mean maximum pain score over 10 days following the IND surgery. The analysis of the primary outcome between groups was performed using a Wilcox rank sum test, where the p-value is 0.05. And this is the consort diagram, sir, where we can see that enrollment is 1334 patient, randomization 433, among them 213 allocated in the packing group and 220 allocated in the non-packing group. And this is the result of analysis, that 126 non-analyzable primary outcome date and analyzed 145 non-analyzable primary outcome date n is equal to 75. Result. In total, 433 participants were recruited between 1st February 2018 and 1st February 2020 across 50 hospitals of NHS Trust in UA. Of those, randomized 213, 49% of 433 were allocated to the packing group, 222, 51% in the non-packing group, 18 in the packing group and 18 in the non-packing group didn't receive the allocated intervention. The reason for the treatment arm crossover were as follows: 5 found packing too painful, the cavity was too small to pack in 3 patients chose not to receive packing, and 3 were crossed over in error, and 4 participants received a combination of packing and non-packing. The reason for crossover from non-packing to packing are as follows: 3 participants choose to pack for fluid control or toileting, 4 made a medical decision to pack, 8 participants choose to pack, and 3 were crossed over in error. Result: The follow-up was completed in June 2020, 6 months after the last participant was recruited. In total, 98 among 213, that is the 46% participant in the packing group, and 107 among 220, that is 49% in the non-packing group, completed the trial as per protocol. And this is the diagrammatic representation of the daily mean maximum pain score, and we can see that non-packed group, the mean maximum pain score is less than the packed group. Primary outcome, the mean maximum pain over the first 10 postoperative day was significantly lower in the non-packing group. Mean difference was 9.9, and which was 26.2% reduction in the pain in the non-packing arm versus the packing arm. In the packing group, 126 among 213 patients of participants had analyzable primary outcome data versus the participant in the non-packing group. Secondary outcome, the pain score both during the dressing change and after the dressing change favored the no packing group. Secondary endpoint, fistula was seen by 6 months of follow-up in 32 among 213 patients of the packing group and 24 among 220, that is the 11% among the non-packing group. So the fistula formation is also very less among the non-packing group, like the pain sensitivity or complaining of the pain. Despite no detectable statistically significant difference, the odd ratio of or no statistical significant difference, the odd ratio of 0.69 reflects a likelihood of lower fistula rate in the no packing group. However, this study was not powered to detect non-inferiority. Secondary endpoint, abscess recurrence was low. 7 among 213 patients, that is 3% in the packing group, and 13 among 229 patients, that is 6% in the non-packing group, likely favoring the packing group, but with a wide impression around the confidence interval and no statistically significant difference detected. Global assessment of care was reported as either good or excellent by 90 among 125, that is 72%, and 120 among 141, that is 85% in the packing group and non-packing group, respectively. The p-value is 0.033. Secondary endpoints with respect to patient satisfaction with wound management, 85% and 94% of the participants in the packing group and no packing group respectively agreed or strongly agreed that they were satisfied with the way their wound was managed, and approach statistical significance was p-value with p-value is 0.062. 65% of the packing group versus 80% of the non-packing group had returned to work 21 days after the incision and drainage. So it is 80% for the non-packing group to return the work 21 days after IND, where it is the 60% only for the packing group. And this is the primary outcome sensitivity analysis, where stratified mixed model, per protocol model are there, and the packing group, non-packing group, 220 non-packing group, 213 packing group are present. This is the table set, packed and non-packed group, where we can also see that probability to return the work is early for non-packed group than packing group. So the discussion, PPAC-2 trial has demonstrated that postoperative perianal abscess wound cavities managed without internal wound packing result in significantly. Yes, sir. Hello. 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 Am I audible, sir?
Yes, you're audible.
Okay. The PPAC-2 trial has demonstrated that postoperative perianal abscess wound cavities managed without internal wound packing result in significantly less pain without significantly increasing adverse event of perianal fistula and abscess recurrence. Pain with no packing group was significantly reduced compared with the packing group, quantified by the primary outcome of mean worst daily pain score. Additionally, pain was significantly higher in the packing group during the dressing change, which persisted afterwards. The main limitation of this trial are the loss of primary outcome data and non-blinding of the participant to their treatment. Non-blinding of participant may have lead to bias in patient-reported outcome. The study has challenged the dogma of the wound packing after IND of perianal abscess and found it to be unwarranted. And this is the reference. And thank you, sir.
Good morning. Makhanda, আমি কিছু কথা বলবো?
Yes, please.
I, Dr. Somindranath Bosak, although worked in cancer hospital, but because I have worked a considerable time in Risra and Shirampur subdivision, I have seen this. I do not like to pack the wound, point one, because if we think of the pathology of the wound healing, is basically wound contraction. So if you pack the wound, then the wound contraction will be less. So I don't pack. First day I pack the wound because to stop the bleeding from the granulation tissue of the wall. But from next day onwards, I usually do not pack. Point one. And I put a Megahil gel or betadine gel and mixed Megahil, betadine and Lox gel in the area and put a cover. This is one. Two is I do a continuous interlocking stitch on the skin margin because I have seen sometimes skin margin is very vascular and perianal skin area and bleeds. Two. Three is what we have discussed is very important in perianal region, be it a fistula or be it a abscess drain. Thing is that it is a cryptoglandular infection and it is in the intersphincteric plane. So what I personally do, I first delineate the cavity with the methylene blue or Jensen violet. Abscess cavity or the fistula, everything I delineate. Then at the proposed site of the cryptoglandular infection, if you do a fistula operation and or abscess drain, you have to burn out the cryptoglandular infection or scoop it clean. If the scooping and burning of the cryptoglandular epithelium is good and you can eradicate the recurrence of the disease. If there is persistent of the cryptoglandular infection in the intersphincteric plane, we have to identify the intersphincteric plane. Then the recurrence is more. 3. 4, what I do, I personally explain, it has been pointed out here also, I personally explain the dressing to the patient and I always tell them when you go to the toilet, proposed time of your toilet in the morning, you take a good painkiller, paracetamol tablet with your tea and then go for dressing or whenever you are planning for dressing and think you take a tablet, Calpol tablet half an hour before and then you go. That relieves the pain. And sometimes I use Lox jelly while putting the Megahil, betadine and I put some Lox jelly. That also causes local pain relief. These are the few points and I am not in favor of packing. In the district area and subdivision area, you will see this is a very old habit and there are quacks and dressers who work in the locality. They always pack the wound tightly. I have repeatedly trained them not to pack the wound because it will hinder the flow of the effluent and the fluid and the toxic material and that will be there and that will cause a delayed wound healing. So packing should be strictly discouraged and we have to tell the people the rationale of not packing because we want the fluid, effluent, dead tissue, everything pus should be drained freely so that the wound becomes clean. So these are few tips from my end. Although I have not published any paper, good painkiller good interlocking to prevent bleeding. Do not pack. Do not pack. For the first day, you can pack lightly, but from next day onwards, do not pack. Explain the patient for dressing and thing, and burn out the cryptograndular area properly. Thank you. Thank you for giving me opportunity. Thank you.
The incision, large pushed incision margin, it is not necessary to widely deroof the perineal abscess cavity. Number one. Number two, the idea of packing was to prevent bleeding. That if you don't pack, there'll be collection of purulent material again in the abscess cavity. So this dogma was there not even in the rural areas. Even in medical colleges, people in the habit of putting a tight pack, and then in the follow-up
Exactly.
also, people used
Yes,
to
sir.
pack the cavities. So this it was discussed in the last colorectal meeting also, that it is not necessary to pack. And you see the incidence of subsequent fistula formation, recurrence of abscess is comparable or even less in the non-packing group. And definitely the pain is much less. What they are
Yes.
trying to say is they have assessed the pain score during dressing, during packing, and immediately after the packing. Not giving analgesic, just a study of the pain score and different phases of dressings also. So I think this should be a practice changing presentation where you should keep in mind that the packing and wide deroofing, a wide deroofing also is not required. It is just an abscess drainage, and over energetic breaking the loculi is also not recommended. You can
Yes.
just drain and irrigate. If you do a good irrigation, that causes drainage of most of the abscess. Okay, over enthusiastic breaking of the loculi can result in a fistula rather than breaking the loculi and draining it better. So a packing is not essential. You can do a light packing in the first post-op day, and then afterwards there is no role for packing. It's just a non-packing dressing. Bath followed by non-packing dressing. You got any cross reference, Mamita? Any other presentation?
No, sir. I just see or follow this journal also only.
Okay. When you present journal club, you try to find out that whether there is such similar publications which can be a additional discussion point for such practice changing publications.
Definitely, sir. Okay, sir. Okay.
Thank you all.
Mahanda, one point. Mahanda.
Yes.
1 point. The Professor Saha has told you a very appropriate thing, and this you, not only for fistula or abscess. This we all should remember that in surgery, it is very important to do the whatever is required. Don't do anything over enthusiastically, and surgery should be very measured. In any discipline of surgery should be very measured, and you should do appropriately and whatever is required. Makhanda has don't do anything over enthusiastically in surgery. Surgery is very measured and do appropriately. Here our purpose is to drain the abscess and clean scoop out the cryptograndular infection and the appropriate area of the cryptograndular area. And we have to clean the area, and no need of excess cutting because it will damage the sphincter and it will damage the whole area. And this is very important.
Actually, this paper has excluded the patient who already had a fistula.
Yes.
Patient who has already has a fistula being developed, they have excluded this from the study. They wanted to study just the abscess, which is not completely the fistula on table. Because again, fistula on table is again a question of debate. You either do primary surgery for fistula at the time of abscess, or you wait and then go for the second time. So they have just included only the patient with abscess, not with fistula on diagnosis. Mamita, I think that is the statement.
Yes, sir. Yes.
They have excluded the fistula who are already.
Yes, sir.
So this was a study. It's a good study to compare packing versus non-packing, and it is established that non-packing is superior to packing. less pain. And-
Actually, sir, in my 11 month of traineeship, I only get this kind of patient in my actually on every at day in peripheral medical college like Bankura Sammelani Medical College. That's why I choose this topic.
What is the
At
practice
least
in
we
your
can
institute?
able to
What is the practice in institute? What most of the people do?
packing, sir. Usually, and
Packing.
still now I
Okay.
saw
Most people
the
do
senior
packing
to
and the
give the pack.
initial 24 hours light packing is allowed. What you do in the immediate post-op period, on the first, second, third, before the patient is getting discharged, you advise the patient to repack the cavity, or you just do a seize bath and then clean and then do a just surface dressing.
Pack the cavity and then started the seize bath after
Because
48 hours.
understand, it's very painful. If you send the
Yes,
healthcare
very much
worker
painful.
to pack,
Hmm.
and in the post-op period again is quite painful to have
Hmm.
the cavity being packed.
Hello.
Yeah, most of the place it is packing only.
Makhanda, can
Yes.
I add a single point? Simple point.
Yes.
Whether male or female, I advise wash it clean, use a seize bath, put meghyl, betadine, and lox jelly mixture, and use sanitary pad. That's it. Don't put pack. Use sanitary pad. When it is wet, change it. Sanitary pad is a simple thing which will give a cover to that area and absorb the fluid and effluent, and it will not stain the undergarments, or the dressings will not be wet. Just use buy sanitary pad and use it. That's it.
Okay,
This is
sir.
my tip to all.
Yeah.
And another important point I want to mention, that you, the postgraduate trainees, should learn this operation properly and all these modern things what Professor Shah has discussed, because in West Bengal our food habit is rapidly changing. And you will get many more cases like this in future. Thank you.
Now, this is a very common surgical entity in our practice. In
Uh-huh.
emergency,
Oh.
you get these abscesses, and you see, if you do a proper surgery, the complications of fistula formation, recurrent abscess will be much less. But what I'm trying to say is, don't be aggressive in managing perineal abscess. It is not necessary to make a very large incision. It's not necessary to break all the loculi. What you need to do is uh, drain the abscess, irrigate it properly, and if there is a actual fistula, you can manage to do a fistulotomy at the same time.
iPhone project.
Okay. Thank you. Thank you, Dr. Momita. Thank you, Dr. Diptaman.
Thank you. Thank you,
Thank
sir.
you.
Thank you so much.
Thank you.